prevalent in the community. And I just kind of want to talk about it, give you some background. So when you're approaching your clinics to, talk about the graphs, you can have a little more background knowledge on what they're dealing with when they're talking about venous ulcers. Um, so yeah, let's get into it. And I'm here in San Antonio, so it's like the wound capital, I feel like, of the state and the country. But yeah, definitely. If you have any questions, we can definitely talk. So let's talk about a little bit about venous ulcers, the risk factors, assessment and diagnostic criteria, the pathophys a little bit, and how we manage them. And then I want to talk a little bit how we treat them with the traditional wound care. And I'm going to talk about the types of compression therapy that we use to manage the wounds before you get to when they're ready for like graft placement. And then other therapies that are available to us in conjunction with our treatment. And then talk about how you manage them long term to keep the ulcers from reoccurring. So the venous disorders, you have these chronic venous disorders that can be considered mild, which are just a simple varicose veins, and to these more complex conditions like deep vein thrombosis or actual venous ulcer. These chronic venous disease refers to more complex subsets such as DVT or chronic venous insufficiency and venous ulcers. So just for reference, lower extremity venous disease equals chronic venous disease. Okay, and the CVD refers to leg manifestations of venous hypertension and the functional abnormality of the venous system. Okay. And so the epidemiology. So the venous ulcers are the most common lower extremity ulcer, which make up 80 to 90% of all leg ulcers. These
Hey,
lesions.
Ruben.
Yes.
Ruben, I don't mean to interrupt. I don't
Yeah.
think your slides are moving forward. It's still
Uh,
showing the first slide.
yeah, this happened again. Okay, that's why. Let me come back. I might have to do it the other way again. Uh,
Okay. Let's see.
you'll probably see it. Okay, how about there? Is it
There we
moving?
go. Yep.
Okay. Yeah, so I'll just do it this way then.
Okay.
All right. So yes, the venous disorders. The venous ulcers are the most common lower extremity ulcer. They make up 80 to 90% of all leg ulcers. And these lesions develop as a result of the skin and tissue changes caused by the valves. They get real leaky and causes venous hypertension. And the management is to reduce this swelling and prevent the skin from stretching and developing the ulcers. Okay. And then once they're healed, the long-term disease management is really, there's this long-term disease management with like compression or prevent it from reoccurring. So we'll kind of talk about that a little bit. But to understand the epidemiology, 2.5 million Americans develop venous ulcers each year, which contributes to about 2 million workdays that are lost annually. And this can occur in folks as young as 20 years old, and it peaks in around age 60 to 80. And there's really no racial predilection, but I have noticed that the female gender is a risk factor. And the lower extremity venous disease, it affects about 7 million people in the US. It's a 2.5 to 3.5 billion with a B is spent on management of these ulcers. And the lifetime cost per individual could be approximately $40,000. The recurrence rate is from 6 to 28% within the first year and 40% within 5 years. And recurrence is failure to address the primary problem. And that's really what ends up happening is the patient is not compliant with their therapy and re-ulcerates, or they might hurt themselves, like bump their leg on something. Education, social support, access to care, those are essential for long-term management. So the venous structure and function, the veins of the lower extremity include deep veins, superficial veins, and perforator veins. These perforator veins, I have a picture on the next slide, so you'll kind of have a visual on there. But they can connect to the superficial veins, to the deep veins, and then transports blood back to the heart. There's approximately 200 perforator veins below the knee, and these veins are filled normally by slow capillary inflow. They have one-way valves that prevent this backflow, so the blood doesn't pull back into the legs. It's able to keep working its way up. This is in a normal physiology, not in a disease process. So as long as these valves are competent, the blood flow will return to the heart in a normal fashion and won't have any issues. But 50 to 60% of the patients with venous ulcers have these incompetent superficial perforator veins, these valves. So the blood starts to pool in the legs. So returning from the blood from the feet and legs is a challenge because you have this, you're working against gravity. We're always working against gravity, right? Whether it's our wrinkles or our veins. So you always want to, that calf muscle pump is what helps get that blood back up to the heart. But it's the prolonged standing that these folks do, or sitting, that causes their problems. So here's my little visual there. You got the posterior arch, the posterior tibial, and then those perforator veins. That's how they feed. And then the normal venous disease on the legs is well, so the normal veins are healthy here, so it closes right behind as the blood's pumping up, so there's no backflow. In a diseased leg, as you can see where the backflow and this blood starts to pool, and that's where you get the swelling and then the ulceration will eventually occur. So chronic venous disease, the three elements of normal venous function are competent valves, physical property of venous wall, and normal functioning of the calf and muscle pump. Most patients have this multi-system valvular incompetence, where the perforator valves incompetence is probably the most common, and the effect becomes magnified when there's more than one valve that becomes, kind of defective or incompetent. And the foot and calf muscle pump, that's what helps really get that blood return back to the heart. But it gets there, for whatever reason, the patient can't move or mobilize, and it's going to cause problems. So these risk factors are obesity, pregnancy in some women. They get thrombophlebitis, they have some leg trauma or blood clot conditions. And then risk factors for the calf muscle pump dysfunction, sedentary lifestyle, job that requires prolonged standing, any paralysis, arthritis, advanced age, which causes a reduced mobility, any altered gait, or any kind of knee surgery. And then, of course, your IV drug use or, injection, people who are injecting their legs with opioids. Your assessment with the patient, you want to get a good medical history, an ulcer history, how long they've had it, any previous treatment, have you seen anyone else for this wound, your clinical exam, you want to assess the ulcer, is it healing, not healing, is it infected, get a family history, oh yeah, everybody in my family has this vein problem, kind of learn those things, and the Doppler assessment of pulses. Now, I bring up this assessment because this is going to pertain to the IVR. They're going to want all this information. So just keep that in mind. Sometimes you want to have that knowledge to provide your clinic, whoever you're talking to, about when they want to get these grafts, that they get a good assessment history of the wound. Because I've seen some poor notes and I'm like, this isn't going to get approved. We got to really tell the story of this wound. So the better the story, the better it can get approved. So that's just something to keep in mind. So the patient history, you want to identify the risk factors, can determine venous insufficiency from arterial insufficiency, because they can always have one or both. And then you want to determine if there's any other issues that can cause the ulceration. It's important to identify any contraindications to compression therapy. If they're in heart failure or if their heart cannot tolerate, increased fluid overload because you're squeezing their legs, you're going to push all that fluid back up to their heart, and if they get overloaded, they can, develop respiratory problems. So you want to be careful of that. And so you want to do your lower extremity assessment. You want to examine both legs, look at the general appearance. Are there any trophic changes like lipodermatosclerosis, which is hardening of the skin. You kind of get this real tight looking skin. It's kind of interesting. Do they have edema? Is it from the ankle going up to the knee, or is their entire leg? It's an entire like cylinder. You know, it doesn't have any contour at all. It's just straight down like an elephant leg kind of thing. Those can be a bit much. Are there any varicosities? Are they having pain? Is it worsening when their legs are dangling? Does it improve when they actually get compression wraps on their legs? Because over time they're like, wow, I really need my leg wrap because it's hurting. I'm like, it feels better when it's compressed. Like, yeah, it really does. So you got to watch out for those too. Is there perfusion? Is there any coexisting arterial disease? So you want to make sure that we get some arterial Dopplers done and also check for DVT in case you want to miss a blood clot for sure. But then also you want to make sure their arterial flow is good, because if you start to compress them with those wraps, you're going to cut off circulation if they have poor circulation. And I'll get to that, why it's important to check that as well. The lower extremity assessment, again, the ulcer characteristics, the typical venous ulcer will occur in the gator distribution area. So you want to see this area, typically see the wounds. They drain a lot, so that's where the high exudate can happen. They usually have irregular edges. The peri-wound can be macerated or kind of really moist, kind of like they've been in the swimming pool for a long time. Sometimes there's scaling, crusting, there could be swelling around it. Sometimes there's exposed tendon. And if there is, then typically there's an arterial component in there. So just want to make sure that's being addressed. And every now and then I throw some pictures in there. So that's a rather large venous ulcer here. And this patient had a vac on, so you can kind of see how it's real vibrant, beefy red granulation tissue. And they're also undergoing compression. This lady, she had been in a Una boot, and it wasn't doing too well. So I got her. I'm seeing her for the first time, looking at her legs. I'm like, yeah, we need to probably change it up a little bit. I just put her in compression for another 5 days, and it just already perked up. So just kind of see the improvement with just compression alone. Nothing too fancy. Of course, they're in the hospital, so their legs are up, and that's easy. The real challenge is when they're home and they're walking around or not walking around and their legs dangling. So just kind of see different types of venous ulcers. The management, limb elevation. It's kind of difficult to tell your patient, yeah, go home, lie down for 2 hours, get your legs up. But it's not it's not practical for some folks. Exercise can be a challenge as well. They might have arthritis, they can't walk, ambulate. There's some type of barrier to them doing any type of activity, but it's always encouraged. Weight control, there's always obesity that you're fighting against. So that interferes with the venous return. And then there's pharmacotherapy that we can try. Pentoxifillin has been around a very long time, and it does work. That can make the platelets less sticky, improve circulation. There's also micronized purified flavonoid fraction, which improves the venous tone. I'm actually a big fan of this one. The real expensive one is probably called Vasculera. It comes from orange peels. Like, it's pretty cool. It is rather pricey though. And then horse chestnut seed extract. I've actually used this in the past as well. It can help reduce edema. The price has changed quite a bit on that supplement though, but it can work, and you just have to be careful if there's no interactions with their other drugs. But these are some things that are being used for direct pharmacotherapy to help with the edema control, in addition to compression. So management, this is your bread and butter right here, the compression therapy. You've got your standard treatment for chronic venous insufficiency, and the venous ulcers will heal faster with compression than without. So that's a given. That needs to be managed. The compression wraps apply pressure externally from the base of the toes to just below the calf. And this helps oppose that leakage of the fluid into the tissues and puts it back into the lymph vessels. So without this compression, the blood's going to pool into the leg, and it's going to keep stretching the skin, and it's going to help either if they don't have an ulcer, it's going to ulcerate, or it's going to make that ulcer bigger, and you're not going to get anywhere. Okay. This is the multi-layer compression system. I think one of the brands is like Pro4 or something. So it's this 4-layer system. You have a cast padding layer, you've got a Curlex layer, and you have a ace wrap layer, and then you have the Coband layer. It's all fancy now. And back in the day, I used to have to build it myself. So it's nice to have that kit. You just pull it off the shelf and you can apply it. The Uniboot is the old tried but true. Some more static compression. I'm not a big fan of it. It's a little messy, and it's a static compression where it doesn't have any give. If the leg stretches, it's not going to stretch. It's just the patient can have problems. It's more like feel like a cast in a way because it dries pretty hard. This one will have a little give both ways. If the leg shrinks with the compression, it'll kind of go with it a little bit. But if there's a little stretch to it, then it'll have a little give. So I prefer this system over this one. But you kind of use what you have. And then these wraps, the Ferro wrap or Juscolite or whatever brand they're into, it's fancy. I love it. If the patient can get it approved by their insurance, you just have these Velcro straps, and they just apply them all the way up. Again, these are never the models that you'll see wearing these compression wraps, but that's how they go on. And then there's your pneumatic compression device, which helps mobilize the interstitial fluid back into circulation. Can be used in conjunction with the multi-layer compression. Patient compliance is a factor. Again, this isn't the kind of patient that probably needs this device. They tend to be a much larger patient, and they need help putting it on. So, but these work wonders if the patient can, one, be compliant with it, and two, get it approved by their insurance. But it can definitely help them. And then some surgical management. You got the radiofrequency ablation, you got the endovenous laser ablation, there's vein stripping, perforator vein reflux. So they have that subfascial endoscopic perforator vein surgery, radiofrequency again, sclerotherapy. And then for the deeper ones, you got the valvuloplasty and the valve transplantation. And they're making good inroads on this stuff, on this larger valvuloplasty. I just actually spoke to a surgeon today, and I was quite impressed. That I ran into him because he was telling me all the ways he can help some of our patients. So I'm quite excited. There's people out there who are really working in some vein work. Now, wound care, the therapy is based on the wound bed, and if infection is present, you want to treat the infection and reduce the bioburden. You can do local debridement as needed, and then there's absorptive dressings to contain the drainage. Okay. Adjunctive therapies, you got your wound vac or negative pressure wound therapy, and then there are skin subs, and then there's the split thickness skin grafts. Now with the human amnion, it's biological, derived with the amniotic membrane. It's got the amino acids, the nutrients, the cytokines. It's got all the growth factors. It's wonderful product. Some of the research with the analysis that they've done, amnion with standard of care, like all the compression I talked about, all the wound management, is superior to standard of care. So that's what you want to bring to the table when you're talking to your clinic about it. Some of the criteria: if the wound fails to heal in 30 days with standard of care, they can be eligible for the graft. And there's little things I'll mention here in the next slide. But the cool thing is it's real easy to apply. It's already dehydrated. You just apply it to the wound dry, and you can moisten it on the wound bed. The only thing different with these venous ulcers is they can be very wet. So you want to most likely fenestrate it so that the drainage can pass through the graft. And the nice thing is the graft's double-sided, so there's no wrong way to apply it. Let me get into some other things specific to the amnion. There haven't been any significant adverse events reported. There's no increased risk of complications compared to control group in other studies. And the graft can be used under compression wrap, so those devices I mentioned. And the graft can be used in conjunction with negative pressure wound therapy. There might be little caveats with that. Maybe dialing down the pressure, putting a non-adherent dressing in between. So those we can do a case-by-case conversation about if y'all have any questions about that specifically. But just know that if you could do it. It's just how you do it is kind of what we can walk through. And then the 10 applications, and then the reimbursement. And there's one more thing. Oh yeah. So I got this from there was a few comments that from CMS, right? With the cellular or tissue-based products. And I just want to mention diabetic foot ulcers because that is a specific criteria with the amount of healing. So they want a certain percentage of healing, right, within 4 weeks or 30 days. But for venous ulcers in particularly, there's no, it just has to significantly, it has to fail to progress in 4 weeks, but there's no percentage of reduction. So that's, I do want to mention that there's no percentage of, so when they say, oh, well, it hasn't met that 50% or whatever, well, actually there's no percentage. You can just say, well, it's actually more to do with, is it still failing to heal? So the progress is not as critical. And then just know about the episode is so many weeks per application. And you want to make sure with these venous ulcers that it's there's a vascular evaluation. And that's what I had brought up, is you want to make sure that there's no arterial problem, which anybody who's dealing with a venous ulcer should have an arterial workup to know that they need to do compression therapy to initiate compression, the compression wraps, and progress to the next, stage of treatment. Otherwise, if they don't have a vascular workup, well, the wound's not going to heal without good circulation anyway. And then the debridements, aren't usually covered in conjunction with the applications. And then really the lifelong management, it takes about 16 weeks when compression is used. I know it takes about 30 something weeks when there's nothing used, like no compression. So it takes twice as long for sure. But the recurrence rate is 50 to 70%. And a lot of times it's their comorbidities, the obesity, the lack of exercise, poor nutrition. They're not doing what they need to do. They're not wearing the wraps or the compression stockings. You just have to tell them, hey, you got to put your stockings on once it's all healed up. Otherwise, they're going to swell again, and you're going to be back in the same boat. And this is difficult for some folks. They're got a huge belly. They can't even tie their shoes. So how are they going to put a compression stocking on? So there's devices that are available to them to assist with applying the stocking, that kind of thing. So the key here is to educate the patient, so they're aware of the risks, keep up with their post care, and keep them from re-ulcerating. So that's what I have for that. Any questions, comments, concerns?
Yeah, I had a question.
Yes.
Are we contraindicated with any of those pharmaceuticals that you mentioned to fix reflux?
No, I mean, these won't interfere. It's with this, they're really supplements. The pentoxifilin won't interact with the graft or anything. A lot of people, it's really fallen out of favor. That's something you can use. I don't know that anybody's really using those things outside of what I've seen. I'm a little more holistic, so I tend to use those things more. You're talking about the pentoxifilin, right?
Yeah.
Yeah. And sometimes people get nervous to use it. They feel like they have to monitor like INRs and stuff, but they don't have to. It's just kind of depends how comfortable they are with it. There's a lot of side effects too. It can make their stomach upset. And then the flavonoid is pretty expensive. I mean, if the insurance will cover it, that's great. But if it doesn't, it's usually not a pocket price, and rarely these patients will spend the money for it. But if you got a wife or sister that's having varicose veins, it really works. I do a over the counter one that's like $15 on Amazon. So, but it can help. Yeah.
Nice, thank you.
But it won't be intricate. It's not contraindicated. It'll just help them out.
As you manage some of these wounds, these venous wounds in particular, what's your criteria for deciding to put a graft on versus, you've exhausted other things, but what kind of goes through your mind as you're evaluating whether or not to put a graft on?
Well, it's it's got to be free of infection. If we're at the 30-day point, then we can certainly, like this one. I know this one isn't because he wasn't eligible. So this one we had to do the old-fashioned way. So it's not quite ready now, but more cleanup on the debridement. So it's several weeks. He's probably another month away. If he could get a graft, he would be eligible. Just because we want to make sure it's a clean, healthy wound bed, free of infection. And if we're at the 30-day point, then yeah, you can certainly do it.
Hey, Ruben, there's a question in the chat that said, do you have any before and after pics?
I don't have any of those. I need to get together. I need to get some of those like wow photos for y'all. I haven't quite gotten there yet on the on that just yet, but it's more to come. We're going to be doing this pretty often, so I hope to have some more down the road.
Any other questions, guys?
None for me.
All right. You good, Ruben?
I'm good. If there's anything else, I know it's a little, it's interesting. These venous ulcers, they're rough. They're rough and tough.
When I have another question for you, whenever you do put a graft on, how often do you use a vac over the top of the graft?
It just depends on the drainage. So, my preference and the provider that you're approaching with it, it's not as frequent, and you can do it without, but some people just want that extra comfort that the vac might be there to hold it on a little better sometimes. And you don't necessarily have to put the vac on right away. You could put the graft on for a few days and then apply the vac on a few days later. So it just kind of, I would wait a few days sometimes. Sometimes I'd put it on right away. It just kind of depends on how much drainage I think we're dealing with, or if I feel like the patient might not be able to keep his dressing on securely enough. So it just kind of depends.
So that's one of your criteria for using a vac if you don't feel like the patient's going to do a good job with their dressing.
Yeah, if they're already on the wound vac, I would add the graft. If I have to order the vac, then I'll have to plan it out a little more to work out the timing. But it's kind of depends what resources are available to me. If the patient maybe doesn't qualify for a vac, or whatever reason, or they just sometimes they don't like dealing with equipment, or they
Sure.
invariably will rip off the trackpad, or they'll just things happen when you have them chained to something. It just can be cumbersome for the patient, and sometimes they just don't handle it well. Or it's few and far between I have to use it with a vac, but if it's available to me, sometimes I'll just take advantage of it.
How do you secure your grafts on a venous ulcer?
We do a non-adherent dressing. Some type of like silicone-based dressing would be nice, like an Adaptic Touch or a Mepitel. And then you can put something absorptive, ABD, or and then you can do it under compression. So with this one, you can do it under the multi-layer compression. So that 4-layer wrap that I showed you, you could do it under that, and that'll hold it all together just fine. And then it could stay up to a week, because that compression dressing could last up to a week. But just depending, so like every clinician will have a gut with their patient in a way. So I might bring them back a little sooner. Let's say I put the graft on a Monday, I might bring them back on Thursday just to make sure the outer dressing is not falling apart. Because sometimes they'll tear up the compression wrap, or it'll stick to things if you don't we put a stocking over it sometimes so the co-band doesn't grip to the sheets and they get all tangled up. So I might bring them back just to make sure they didn't tear up the outer dressing. And I might have to reapply the outer dressing in some cases. It's again, the clinician might have an idea if they need to check on that patient a little more. So it just depends on how they feel about it with their gut on that patient. But it generally could stay on up to the week for the next application.
Perfect. Thanks.
Sure.
Well, all right. If there are no more questions, Ruben, thank you so much. It was an
Sure,
awesome
thank you.
presentation. We've recorded this, so if anybody needs to go back and review it, feel free. It'll be in the Dropbox by tomorrow. Usually takes a little while for Zoom to process the video. So anyway, thanks again, everybody. Again, we do have a call tomorrow that's on sales strategy, and also the founders will be going over our rebate program for the new Revishield graft. So if you can make it, I really encourage you to do it. Thanks, everybody, and have a good rest of the afternoon.
Thanks, everyone.
All right.